Chapter 5 Organ Donation. Solid organ transplantation is a therapeutic option for many individuals with organ failure. For others, it's critical to sustaining life. Although quality of life can improve after receiving an organ transplant, the process is often associated with many challenges. More than 100,000 people in the United States are waiting on transplant lists, and more than 1 million organ transplants have been performed in the U.S. Critical care nurses work collaboratively with organ procurement organizations and transplant teams. The demand for organs is tremendous. In an effort to meet this demand, many states have donor registry programs. The transplant process begins with activities coordinated by an organ procurement organization. These organizations consist of multi-professional teams that handle donor management, the listing of potential recipients, and the notification of available organs. The Uniform Anatomical Gift Act was passed in 1968, and this established a legal framework for individuals to authorize an anatomical gift of their organs, tissues, and eyes after death, and it cannot be rescinded. There's also the National Organ Transplantation Act of 1984, and this created the Organ Procurement Transplant Network to provide oversight, though despite these efforts, donor organs remain scarce. Given the shortage of available organs, efforts have focused on increasing the available organ pool. In 1998, CMS implemented conditions for participation for transplantation. Hospitals that receive Medicare reimbursement must notify the local procurement organization of cases of impending death in order to continue to receive Medicare reimbursement. There's going to be many clinical triggers, which may include loss of neurological reflexes, a low Glasgow Coma Scale, discussion of withdrawal, consulting palliative care or family members when initiating the discussion about donation. The Centers for Medicare and Medicaid Services also provide those conditions of participation for transplantation, as well as early identification of potential donors, along with clinical triggers that may also occur. There are going to be three different types of organ donors. That's a living donor, a brain dead donor, or the donation after circulatory death, or cadaver donor. To be considered as a living donor, certain criteria must be met. For patients with a potential donor that is not a compatible type, there's a paired donation is an option, where they could donate their organ to someone they are compatible with, while the person they're intending to donate to would also receive a compatible organ, as a way to trade and increase the pool. This is only done after a clinical evaluation, with strict criteria being met. Each donor is assigned an independent living donor advocate. They may be related or unrelated. In the case of brain death or death by neurologic criteria, these would be patients that are in a permanent coma, have absent reflexes, or apnea. There's many definitions of brain death, and the determination of brain death is performed by a neurologist. The criteria for brain death are defined as absent cerebral and brainstem functions associated with a non-survivable head injury. For the clinical diagnoses, there are going to be several prerequisites, along with that strict neurologic examination, ancillary tests, and careful documentation. The primary care team delivers the diagnosis. They want to ensure understanding and consider the cultural, personal, and religious perspectives often associated with death. The OPO designated request approaches the family. They help with end of life decisions, discussing organ donation, and obtain authorization for the donation. Separating organ donation discussions from the primary care team is called decoupling. Decoupling has been found to significantly increase organ donation authorization rates. Donation after cardiac death. This occurs when there is no recovery from an illness that's expected. It does not meet brain death criteria, is dependent on life-sustaining measures, and each OPO and transplant center may have different criteria. Donation after cardiac death criteria were initially established in 2007. The donation process occurs within close proximity of the operating room, where organ procurement follows pronouncement. Quick quiz. Which of the following patients meets criteria for donation after cardiac death? That be A, a patient with a massive intracranial hemorrhage without brainstem reflexes. B, a patient that is intermittently breathing over the ventilator after an out of hospital cardiac arrest, but remains comatose on hospital day 5. The family is considering pursuing comfort care measures only. C, a patient who is tolerating spontaneous breathing trials and is preparing to extubate. Or D, a patient diagnosed with septic shock on continuous renal replacement, who interacts with families and is waiting for pressor support. And that answer is going to be B, the patient that is intermittently breathing over the ventilator after an out of hospital cardiac arrest, but remains comatose on hospital day 5. The family is considering pursuing comfort care measures only. When considering the care of the donor family, you must develop trust through advocacy, honesty, and empathy. You want to make sure to provide time to answer all questions, as well as understand the perspectives of the family. Emotional support and grief counseling is going to be critical. Another quiz. The family of a patient who has suffered an anoxic brain injury has been updated the provider on the patient's poor prognosis. They're aware that brain death or death by neurologic criteria determination is to begin. Which of the following would not be an appropriate response by the nurse? Would that be A, approach the family about their options for organ donation? B, provide the family private time to be with the patient? C, support the family by answering questions? Or D, prepare the family by educating them on what to expect during brain death or death by a neurologic determination? And that answer is A, approach the family about their options for organ donation. Donation requests by a trained professional increase the success of organ donation authorization and subsequently the number of organs donated. This is referred to as decoupling. When evaluating the potential donor, we want a careful medical history, including their social and lifestyle aspects, as well as a physical assessment and a thorough diagnostic workup. This patient is going to be assessed thoroughly to make sure that there's no problems that we're going to find out after the donation. Brain death and death by the neurologic criteria include permanent coma, absence of reflexes, and apnea. A permanent coma may be structural, such as the case of a traumatic brain injury or an intracranial hemorrhage. It may also be the result of an anoxic injury, such as drug overdoses or cardiopulmonary arrest. We want to apply the principles of brain death by neurologic criteria to help explain the anticipated evaluation of a 24-year-old that was ejected from a car after a high-speed collision and suffered a traumatic brain injury. Now, that's going to be a very difficult time for the patient and their family, but we also want to make sure that they know of their options. That testing and clinical diagnosis will occur while cardiopulmonary function and end organ perfusion are artificially maintained, such as mechanical ventilation or infusion of a vasoactive medication, maintenance of intravascular volume, and the treatment of electrolyte derangements. Updated guidelines published in 2023 lay out the determination of brain death in 4 steps, including prerequisites, neurologic examinations, ancillary tests, and documentation. When it comes to collaboration between the procurement organizations and physicians, and there can be variables slightly based on the organ donation type, such as donation after brain death or donation after circulatory death. The patient met brain death by neurologic criteria. Over the last hour, the nurse notes the patient is becoming hypotensive with urine output greater than 500 milliliters. The nurse takes the following action: monitor for another hour, then notify the provider. Notify the provider, recommend isotonic crystalloids and desmopressin. Notify the provider, recommend isotonic crystalloids and norepinephrine. Or D, notify the provider and recommend isotonic crystalloids. That answer is going to be B, notify the provider and recommend isotonic crystalloids and desmopressin. The patient is in diabetes insipidus, and fluid resuscitation should occur for this patient, as they'll begin to rapidly lose volume. Desmopressin is replacement therapy for ADH depletion and is the treatment for diabetes insipidus. While the patient may need pressors, the DI must be treated first. Let's talk about the process of donation after brain death. The process begins once brain death is formally declared, and a trained requester obtains the authorization for donation. Brain death results in autoregulatory loss. Therefore, the goal is to preserve organ function. For optimal donor management, we want to replace neurohormonal regulation, modulate pro inflammatory state, replace the intravascular volume, support vasomotor tone and cardiac contractility, and maintain normothermia. Once all organs are placed, the OPO coordinator establishes the operating room time with the donor hospital. All recipients are called into their respective hospitals to begin the preoperative processes. Recipient hospitals send surgical teams to the donor hospital to recover the accepted organs. Once organs are recovered, the OPO coordinator updates the family and provides supportive care. Caring for a patient declared brain dead in transition to organ donor is psychologically, emotionally, and physically demanding. Strategies to overcome these stressors include maintain dignified, respectful care of the body, ask questions to understand, maintain effective communication during the donation process to reduce stressors, and debrief after events. Donation after circulatory death. DCD donors are managed by the critical care team until cardiac time of death. Withdrawal typically occurs in the OR with the RN providing end of life care. Family presence is defined by the hospital's policies. For viability of transplant organs, the time of death must occur within 30 to 60 minutes from withdrawal. Warm ischemic time. This is the amount of time the organ is not adequately oxygenated and not preserved in a cold solution. Cold ischemic time, on the other hand, is how long the organ is in a cold storage solution for transplant to the recipient. The allowable time for each varies based on the organ and factors such as the recipient's need, the donor's health, and the surgeon's preference. If cardiac time of death does not occur within the required time frame, the patient is transferred to a predetermined location. Organ donation processes stop, and comfort measures, end-of-life care, and family support continues. For a transplant candidate, a comprehensive evaluation would include assessing medical and surgical alternatives and determining the best criteria for a matching donor offer. Acuity of the illness typically determines placement on the wait list, and potential recipient is informed of donor information that could impact the recipient's post-transplant at time of offer. Also, discuss the medical and social histories of a potential organ donor that need to be explored as part of the organ donation evaluation. What diseases or chronic conditions may not allow for organ donation? Are there age limits for organ donation? The process begins when the OPO coordinator obtains extensive medical or social histories. A medical history screening includes the presence or absence of any health conditions that may affect the function of both the transplanted organ, like diabetes, hypertension, or chronic obstructive pulmonary disease, COPD. Although active cancer does not automatically disqualify a potential donor, consideration may be given to when and how long the potential donor has been in remission, the tumor type, treatment, and follow-up. A social history is also obtained and identifies any history of cigarette use, heavy alcohol use, drug use, as well as sexual history. The goal is to identify any risk factors for potential transmission of bloodborne diseases such as HIV, hepatitis C, or hepatitis B. Any other severe acute respiratory syndromes like COVID, the virus can cause coronavirus disease, and were contraindications to donation at one time, but now those organs are being safely transmitted. Hopefully, we're well past that. Hopefully, YouTube is not still flagging all my videos every time I say COVID as well. There are very few contraindications to donation. However, the coordinator will relay this information to the recipient transplant center to assist in their selection of the best recipient of the transplantable organ. Common indications for lung transplant would be COPD, interstitial lung diseases, or cystic fibrosis. There are also a variety of transplant options, including donor criteria such as younger than 55 years old and fewer than 20 pack years of smoking history. For kidney transplant, the candidate criteria is going to be a patient on end-stage renal disease, like a patient on dialysis. And for donor criteria, this could either be a living donor or a deceased donor, often called a cadaver kidney. For a heart transplant, this is going to be for patients with advanced heart failure that's unresponsive to medical therapy. Additional treatment options would include pharmacological or mechanical assist devices such as an LVADs. There is an upper age limit for transplant candidacy that is 70 years old. Other donor criteria may be over the age of 55, coronary artery disease history, structural abnormalities, or other issues with ventricular function. For a liver, this is a standard treatment for progressive, irreversible, acute, or chronic liver disease when there is no other medical or surgical options. Transplant options include reduced sized liver, split liver, and the donor criteria is again living or deceased, though they should be avoided with advanced age, DCD donors, and liver with intrahepatic fat. The Uniform Anatomical Gift Act. Solid organ transplantation is the only definitive treatment for patients with end organ disease. Awareness of the clinical triggers for organ donation, as well as organ donation that occurs in 1 to 3 donor types: living, brain dead donor, or donation after circulatory death. Remember, the Uniform Anatomical Gift Act establishes a legal framework for individuals to authorize an anatomical gift of their organs, tissues, and eyes after death. Solid organ transplantation is the only definitive treatment, and these critical care nurses should be aware of the clinical triggers for organ donation as established, and they should include the loss of neurological reflexes, low Glasgow scores, and discussion of withdrawing or ceasing life support, consulting palliative care, referral for hospice, or family members initiating a discussion about the donation. Organ donation occurs in 1 of 3 donors: living, brain dead, or after circulatory death. Living donors complete a full medical and psychological evaluation to ensure they're appropriate for donation, and also to ensure they're not being coerced and that they know what they're getting into. Remember, DCD is an option for patients with grave prognosis, whose end of life care involves compassionate extubation, and whose death is expected to occur within a specified time frame post extubation. Authorization for organ donation is obtained either through first person authorization for donation or from a legal authorized representative. Donor families have unique needs that require support for the critical care team. Evaluation of a potential donor is a strenuous process that requires an accurate history and thorough physical exam. Brain death leads to several hormonal, metabolic, and systemic changes that may require volume, electrolyte, and hormone replacement, or vasopressor support to preserve the organs. Regardless of the donor type, organs have a limited time they can be out of the body. Therefore, timely and efficient recovery is key. Each organ has unique donor criteria, and transplantation of each organ has varying success and survivability. At the same time, organ donation is a key part that provides and extends the life of a lot of people. I used to work organ transplant for a Cleveland clinic, and it was a very difficult but very rewarding specialty. But anyway, that's all I got for this slides. I'll see you in the next chapter.